Hello?
My
Hello?
apologies, Kelvin. Please continue.
Okay, sorry about that. All right, so the seminal vesicles are attached, and in some cases you remove the lymph nodes in the pelvis that are associated with the prostate. It's the most common treatment type for men with localized cancer under the age of 70. And in the United States, the most common approach has been is a minimally invasive, so robotic-assisted laparoscopic approach. And that approach gives you excellent visualization of the nerves that serve for erections, which are very near the prostate, as well as for the structures that are important for maintaining continence or the ability to hold your urine. The different types of surgery are retropubic or open, what's called the open prostatectomy, perineal, where the incision is made in the area between the scrotum and the anus. Not a lot of people do that surgery anymore, but it's actually a very nice approach. And then laparoscopic or robotic surgery. The vast majority of men who get surgical treatment can expect a durable response, and it depends on your presenting risk level. So men with low-risk disease have a very low risk of a PSA or biochemical recurrence, and we're in the range of anywhere from 5 to 20%. With intermediate risk, somewhat higher risk of recurrence of cancer, anywhere from 20 to 50%. And then among high-risk patients, there's high risk of recurrence. So these will be anywhere from 50 to 80%. And a lot of times these men will require more than one treatment beyond surgery. Next slide. The main side effects of surgery have to do with the functional aspects that are either controlled by or near the prostate. So the nerves that serve for erection are very near the prostate, and so erectile dysfunction is a very common side effect. Urinary incontinence is not very common as far as total incontinence. Some men will have loss of urine with stressful activity like coughing or laughing. All men who have a prostatectomy have essentially had a vasectomy because we disconnect the tubing that delivers sperm, so you'll no longer have an ejaculate. You can still have children, but you would have to harvest sperm directly from the testis into in vitro. And side effects vary not only on the skill and experience of the surgeon, which is very important, but also the function and age of the patient. Younger patients do better. Patients who have excellent erectile function preoperatively do better. Patients with good urinary control do better. Surgeons who do a lot of surgeries from whatever approach they're most comfortable with tend to have better outcomes. Next slide. So when preparing for surgery, there's a lot of things that men can do to try to improve their outcomes. Any men who wish to have further children should probably do sperm banking in order to do in vitro fertilization. Men who, for any risk of urinary incontinence, should perform Kegel exercises, the same thing we teach women after childbirth, in order to strengthen and rejuvenate the pelvic muscles. That allows men to get earlier control after surgery. And a lot of surgeons now will do what's called penile rehab, preoperatively and postoperatively, using common medications like Viagra and Cialis before surgery in order to optimize blood flow to the penis and improve erections, and then we continue that after surgery. The surgery itself is done under a general anesthetic and usually takes anywhere from 2 to 4 hours, depending on the approach and the aggressiveness of the surgery. And at this point, I will hand it over to Dr. Shinohara for his radiation portion.
Dr. Shinohara, are you there?
Hello. Can you hear me?
Yes, we can hear you.
Okay, perfect. So I was just going to focus in on the specifics of radiation treatment for localized prostate cancer. It's basically divided into two large categories: external beam radiation and brachytherapy, which you saw on the introductory slide. And beginning here, I'm just going to go over mostly the external beam and sort of indications for radiation. And so radiation can be used in two ways. We can be used independent of surgery, where radiation is used to try and cure the prostate cancer on its own, or sometimes with the added treatment of hormone therapy. And sometimes after surgery, depending on what's found on pathology after the operation, radiation can be used what we call adjuvantly as a addition to surgery to help decrease the risk of the prostate cancer coming back. And so we can achieve treatment of the prostate cancer in a couple of different ways. Predominantly what's used now is something called intensity modulated radiation therapy, and this is the most common external beam radiation used today. And it's approximately 8 to 9 weeks of treatments, and they're daily Monday through Friday. There's been a number of groups that have been interested in trying to shorten this course of radiation, and there's sort of two ways you can do this. They're sort of trying to compress this 8 to 9 weeks into about a 5 to 6 week course of radiation therapy, and there have been a number of studies that have tried to compare that with the longer course of radiation. And then somewhat more recently, there's been interest in something called stereotactic body radiotherapy, where you compress this 9 weeks into approximately 1 week of treatment and try and improve the treatment time and potentially the efficacy of the radiation. So those are both under investigation. We'll talk about a little briefly in a little more detail. And then I think many men have a great interest in proton therapy, and we'll talk about that a little bit as well. Treatments generally take somewhere between 30 to 40 minutes a day, and again, it is 5 days a week. So on the next slide here, this is just an example of a linear accelerator, or a LINAC, which is used to deliver the intensity modulated radiation therapy. And it just gives you an idea of what it's like to undergo radiation treatments, where the gentleman would be laying on the treatment table on the picture on the left, and the head of the machine rotates around you as it shows in this picture, and that basically allows us to deliver the radiation dose very precisely to the prostate while keeping it off of other normal organs in the area like the bladder and rectum, and decrease the risk of side effects. And so just to focus in on some of these shorter courses of radiation. So the longer course one, which is going from the 8 to 9 weeks down to 5 to 6, basically gives something more akin to 1.5 times the daily dose of radiation you would see in those longer courses. And thus far, the data appears to show that it's about equivalent to the longer course of radiation as far as curing people, but it does appear to have a little bit more in the way of side effects. So the trade-off is, originally they were hoping that perhaps by using these larger doses of radiation a day that we'd be more likely to cure men of their prostate cancer, and this does not appear to be the case. But it does appear to reduce the number of treatments you can do it in without compromising how effective it is. The one thing you can lose, again, is probably more in the way of urinary side effects, such as getting up more at night to go to the bathroom, or having a weaker stream with treatment and things like that. So that's always a trade-off you have to consider with your doctor as to whether you would want the shorter treatment course but more potential side effects. The stereotactic radiation, they have not done very large randomized studies, but they have a lot of men who have been treated on this, and they've kind of collected the data on how they've done after the treatment. And again, this is now taking something like 4 or 5 days of radiation and compressing that into one treatment, and then giving that bigger dose 5 times. And there, the data is, again, because it's not been randomized, is very early, but again, it appears to be fairly well tolerated, although when they're treating to the very large fraction sizes a day, so sort of when you take the whole week and compress it into one treatment, there does appear to be more in the way of side effects to the bowel, such as more bleeding and ulcers and that type of thing. So again, sort of the convenience factor has to be balanced against some potential increased risk of side effects. Probably the biggest focus you'll see in trying to decrease side effects is in proton therapy. There's a lot of information on this on the internet and things. These photographs or pictures are just here to sort of illustrate what the potential benefit is to proton therapy. So this is actually not from a prostate case, but a pediatric case, which is probably where proton therapy is used the most now. And basically what it's showing is in this top picture, the top sort of colorful picture you see shows what it would be like to be treated with conventional X-rays, and the bottom picture is proton therapy. And it basically shows that sort of purple line stops right at the spinal cord. And that's sort of the beauty of proton therapy, is it allows you to sort of stop how deep the radiation goes in the body. And so it's sort of described as a depth charge by some, as it just goes to a specific depth and just treats to that area. Now, again, there have not been great randomized trials comparing proton therapy to photon-based therapy, and there is a limited supply of centers that can do proton therapy, and it is generally a much more expensive treatment than photon-based therapy. So there have been a number of registry trials and things like that that have shown some conflicting results as to whether the side effects are better or not with proton therapy. And at present, there's not clear guidelines that show that proton therapy should be recommended over conventional radiation therapy, although studies are ongoing, and many of the larger cancer centers with proton therapy are currently running some prospective clinical trials to see if there is a benefit. Some people may have difficulty obtaining coverage depending on what your insurance is because of those reasons, but it is something that's under investigation, more heavily used probably in brain and pediatric tumors at this point. These are some of the side effects that can occur with any of these external type radiation treatments. So generally speaking, you can break these into those that occur during treatment and those that can occur after treatment. During treatment, it's really some urinary changes, like going to the bathroom more often at night, getting up, or during the day, having to make it to a restroom sooner if you get the urge to go. Fatigue, and then loose stools or sometimes diarrhea can occur. Most of this will get better about 4 to 6 weeks after radiation's done. Some of the later side effects are listed here as well. Sometimes a little bit of blood in the stool, almost like hemorrhoids. Sometimes a little more difficulty emptying the bladder. And then there is a very small risk with radiation of causing another cancer to develop 10 to 15 years down the road. The risk is very small, but is a possibility. And then sexual dysfunction, more difficulty getting an erection can also occur. Much like surgery, the ejaculate can basically disappear over time with the radiation treatment as the prostate function decreases. Some of the things that we've been using to decrease the bowel effects can be decreasing dairy or caffeine intake. That can also help with the urinary symptoms because sometimes coffee and tea can cause some urinary urgency. Usually with the new modern IMRT techniques, you don't really see much in the way of skin irritation anymore. There are some products out there where they're trying to reduce the risk of side effects to the rectum by actually injecting some gel between the rectum and the prostate, which basically allows a large reduction in the dose that goes to the rectum. And again, not well studied, but probably a smaller risk of side effects with that. Next is brachytherapy, which comes in 2 versions, high dose rate and low dose rate. It still needs to be performed in the operating room. oftentimes with the aid of a urologist like Dr. Moses. And what we do is with low-dose radiation, we put some catheters into the prostate seen in this picture below. And you can see as the catheter is withdrawn, you can leave radioactive seeds in the prostate, basically to treat it from the inside out. So with the low-dose rate, as alluded to previously, it's actually putting the radioactive seeds into the prostate. So it's usually reserved for men with low or intermediate risk prostate cancer when used alone. Some centers have combined it with external beam radiation and hormones in men with high risk prostate cancer. These are just some more pictures of the process. Again, you would be going to the operating room with a rectal probe similar to how a biopsy is done. And then using a needle template, which you can see on the right-hand picture, that's what's used to introduce the needles into the prostate. And then basically a seed gun is used to put the seeds into place. Because these are permanent seeds, you are radioactive after the procedure, so we generally ask you to limit your contact with pregnant women and small children during that time period because of that very low dose of radioactivity that's being given off. High-dose radiation, again, is oftentimes done with urologists involved, and we put actually just hollow tubes into the prostate in the operating room. And then using those tubes, they stay in place. You come downstairs to the radiation department, and they actually plan the radiation and hook up what we call a robot, which is basically a fancy machine that introduces a radioactive seed that can move in and out of these tubes, but it gives off radiation at a higher rate, so it doesn't need to be permanently implanted. So in some ways you can have a little more control over how you deliver the radiation, but many of these techniques require the placement of these catheters multiple times, and so that would be one potential downside to the procedure. Side effects are somewhat similar to the external beam, the main difference being more obstructive symptoms because, as you can imagine, we generally put something like 10 to 15 needles into the prostate, and that can cause some swelling, causing some obstructive symptoms. Sometimes seeds can move a little bit, so sometimes men will notice a seed may come out in the urine or something like that. And again, with the low dose rate or LDR brachytherapy, the radioactivity issue for that 2 months as the dose is going down, which is not an issue with the high dose rate brachytherapy. And so just some of the planning or logistics before brachytherapy. There are certain size criteria and anatomical constraints that must be met to be a candidate for brachytherapy, so we do have to do some measurements. And then evaluation by an anesthetist to make sure that other health issues may not interfere with anesthesia for the procedure. And so I will turn it back over to Dr. Moses to talk a little bit about HIFU, cryotherapy, and surveillance.
Can you hear me? Can everybody hear me?
Yes, Dr. Moses, we can hear you.
Oh, all right, great. So some other treatment options we'll talk about now: high-intensity focused ultrasound, or HIFU, cryotherapy, and then we'll wrap with active surveillance. So HIFU is a relatively newly approved treatment, at least in the United States. And what it is basically just like any other ultrasound, but much more high-intensity ultrasound waves. And it's used to and directed towards the prostate, obviously, and destroys tissue with heat pulses from the ultrasound probe. This takes about 2 hours or so, and this is considered another one of the minimally invasive approaches. Most of the trials that were used in HIFU were done outside the United States, but it actually was recently approved by the FDA. There are several practices that now use HIFU, particularly in the private practice world, but even more now increasingly in the academic practices. But you have to make sure that it is covered by an insurance plan because it is relatively new, so the market hasn't quite caught up to it. There are not many long-term data with HIFU, but it looks to be promising, particularly on smaller tumors and lower grade tumors. This has been a particularly attractive one. It's marketed as having less side effects as far as erectile function and incontinence, but it remains to see what the long-term oncologic or cancer control is. Next slide, some side effects. You will have to have a catheter sometimes up to 2 weeks after the procedure, which is similar to what's done with surgery. Some men have it removed earlier. There can be some discomfort associated with it and erectile dysfunction as well. They do suggest that there may be a lower rate of erectile function compared to surgery. And so as we find out longer-term data with HIFU, we'll see if it has similar cancer control with decreased side effects. The vast majority of men who are getting HIFU will have an MRI scan and will have nothing to eat or drink for several hours before surgery. And then some practices will give an enema just to empty out the rectum and make it easier for the ultrasound probe. And this is done either with what is called a MAC anesthetic, sort of like when you do a colonoscopy, or even a general anesthetic. Cryotherapy, and from the root word of cryo, like ice or cold, uses a gas that has a very low temperature. And you insert tubes into the prostate almost like the brachytherapy picture, and using a usually nitrogen gas, drop the temperature quickly and form essentially an ice ball within the prostate. And what that does is it destroys cancer cells within the prostate as well as normal cells within the prostate as well. And so we have to be careful, again, with nearby structures like the urethra and the rectum, which are nearby. This can be a more cost-effective procedure and has been approved in several settings. Probably some of the most common settings we see it now are in low or intermediate risk cancer patients, and also in men who have received radiation as an initial treatment and then have had recurrence within the prostate and get post-radiation cryotherapy. Next slide, we'll see the side effects, again, all sort of similar: urinary incontinence, erectile dysfunction. Incontinence, usually not as common as surgery. Erectile function, almost definitely, because you're creating an ice ball which freezes all the tissue within the prostate. Some men may see some blood in the urine and soreness, and some other side effects can be particularly devastating, like a fistula or an abnormal connection between the prostate and rectum. And so we have to be very careful. They use a warming catheter in the urethra and will prevent the ice ball from getting too close to the rectal wall. And lastly, we'll talk about active surveillance. And this is something that has become much more commonly used in the United States and really around the world. And it has become the preferred treatment option for men with low-risk localized prostate cancer. And what active surveillance does, it allows men to be followed closely with PSA measurements, repeated biopsies, and sometimes integrating MRI, and allows most men to avoid treatment, and then for others who need it, can delay it so that they'll have more quality of lifetime before they experience the side effects of treatment. This is attractive because we know that at least half of men have low-risk disease, meaning their PSA is below 10, their Gleason number is 6, and they have a normal exam. And we know that a lot of men will never die from prostate cancer. So this allows men to follow along closely without letting the disease grow and get out of the box in cases where there is some aggressive cancer. So as I stated on the next slide here, you usually get a PSA test every 6 months or so. You will get repeated biopsies. You usually get your initial biopsy and then another one within 6 to 12 months. And then as you're following along, you'll get them any frequency between 1 and 3 years, depending on what your PSA does. This allows you to be monitored closely without allowing the disease to spread, or at least lower risk of spreading. This requires an excellent conversation between you and your physician so that you set goals for any changes that would trigger either another biopsy or moving on towards treatment. So let's discuss some of the lifestyle changes and the things that you can expect after treatment with localized prostate cancer. One of the things that has gotten to be very important in the literature is showing that your overall health has a lot to do with not only your cancer-specific survival or recurrent, but your overall survival. And so overall wellness is important. Exercise, a good healthy diet with lots of vegetables, fruits, lean meats, good fats, or avoiding simple carbohydrates. And also good support. So utilizing spouse, family, or friends, your physician, sometimes patient navigators can all help because most men, as we said, even after 5 years, are still living with cancer that have survived. And it helps to have a support group. And that's one of the great things about Zero is that they have resources available for survivors of prostate cancer. So when coming down to the decision, you have to decide what's important to you. When I discuss with men, I place cancer as the number one priority, urinary control as the second priority, and then erectile function. But the patient also has an input, and so they want to know, you have to weigh the risk and benefits of what your erectile function will be, what your family status is, what your income status, what your risk classification is, and your time, if you're still working versus retired. So there's a lot of things that you have to take into account. So discussing with friends, family, spouse, hearing from other patients or survivors who have similar disease to you, and some things to take into account when you're talking with your doctor on the next slide. What is your status? What risk level are you? And a lot of times your risk classification gives you or lets you know what your options for treatment are. And always ask questions of your surgeon or your radiation oncologist. What are all the options? What is better than the other? What is the data that suggests that? What is that person's experience? How good is the hospital with that? If you're having surgery, you want to know what their post-op results are. If you're having radiation, what their complication rates are. Sometimes getting a second opinion gives you the opportunity to sort of digest that initial blow of hearing a cancer diagnosis, but then can give you another person's opinion so that you have all the options available to you. And then one important question is treatment necessary? Do I have to receive treatment now? Can we wait? Can we go on surveillance? And so these are all things that you'll want to discuss with your physician and any second opinion. And essentially, you want to stay informed and stay involved. That's by asking questions, going to Zero's website or the American Cancer Society, talking with another physician, and educating yourself. Ivy, I think I'll turn it back over to you.
Okay, great. Thank you so much, Dr. Shinohara and Dr. Moses. We learned quite a bit today, and thank you to our attendees. We've gotten some great questions. I'm just going to talk to you guys a little bit of how you can connect with us at Zero. We are here to help you or your loved one, through your prostate cancer journey, and we have quite a few resources that are available for you. You can learn all about our programs and resources on our website. We have a monthly electronic newsletter which is sent out on the second Thursday of the month, and we certainly encourage you to participate or volunteer in one of our local run walks. They're great programs, they're lots of fun, and it's a wonderful way to increase awareness. And we also have a great program called Zero's Heroes, where you're able to share your story and empower and educate other men and loved ones about your journey. And if you specifically have questions, you are welcome to reach out to me. I am the head of patient support services, and that's my email, ivy@zerocancer.org. You can also find me on the website, and my phone number is 202-280-6173. And with that, I am going to kick it over. We've gotten some good questions, and I'm actually going to start. We got a couple of questions about active surveillance. And so one of them was specifically a gentleman is unable to have an MRI because of a defibrillator, and he wants to know if he would be a candidate because he can't have an MRI-guided biopsy. And the other question, sort of to circle in around that, we'll follow up on is life expectancy, how in sort of long-term life expectancy with low-risk disease. So if you could talk a little bit more about just active surveillance, Dr. Moses.
So you can definitely get on or get active surveillance even if you cannot get an MRI. The MRI can help guide as far as tumors that are in unusual locations, or if there's a larger tumor, you can target it with your biopsy. But not being able to have an MRI does not preclude you. You should still get a repeat biopsy after you're diagnosed, and your physician may take extra biopsies compared to the initial one. So normally people will take 10 to 12 biopsies, and if you're going to get a repeat one, they should probably get some extra ones in what's called the anterior zone of the prostate, just to make sure they're sampling all of it. If you're being considered for active surveillance, you likely have low-risk disease. And anybody with low-risk disease, their survival, overall survival and cancer-specific survival is 99% at 10 years and at 15 years. And so you should expect a very good survival. The chance of the PSA rising is still fairly high, and so that's why it needs to be followed closely. But if you have low-risk disease, the chance of you dying from it is, in the 1 to 2% range.
Excellent. That is very helpful, and I think that certainly answers that particular question. We actually also, so this is a little bit more about testing, but we have somebody who says that their urologist does not believe in PSA lab tests, and he insists. And if you could just talk very briefly a little bit about what the benefits and risks of using or not using a PSA test could be. And we don't know if this gentleman's been diagnosed, so I'm just going to talk, maybe you can just generally talk about the using PSA testing for screening.
Okay. So PSA is not a yes or no answer test. And so there's not a particular number that tells you, yes, you have cancer, or below which, no, you do not have cancer. So we have to be a little more savvy and sophisticated about using PSA. And so we do use PSA. We use it in conjunction with the rectal exam, the patient's age, health status, comorbidities, anything like that. And so, in effect, probably what the urologist is saying is that it's not terribly reliable as far as diagnosing cancer. That's why we have to do the biopsy. Now, after diagnosis and after treatment, PSA becomes an exquisitely sensitive test, meaning any increases in the PSA likely reflects a recurrence of the cancer, and that needs to be addressed. So we still use PSA for screening, but we have to be a little bit smarter about it as far as how much stock we put into any particular number. Eric, do you have any other words you think about that?
Yeah, I completely agree with you. It's one of those things. I think a lot of people think the test is bad, and it's not really the PSA. It's the problem. I think I agree with Kelvin. It's sort of what you do with that information once you know your PSA is elevated. It really just sort of guides you as to whether you want to consider a biopsy or not, and that's something to discuss with your urologist as well. And I think one of the things that they've been trying to avoid is over-treatment, but I don't know that it's always – I think most people would rather know than not know and then make the decision. So I think that's the difficulty with PSA. It's not bad information. It's just how you process it, and it can be complicated and involve a lot of conversations with your urologist or a radiation oncologist to figure out how you want to proceed with that information.
Excellent, thank you. I think it's a great conversation about sometimes a tough topic. So thank you for both the perspective of in testing as well as in using it to manage disease. So Dr. Shinohara, this question is for you. Could you talk a little bit more about how late or at sort of when a man may start to see side effects as a result of external beam radiation therapy? Like, is it possible to see, like 1 to 1.5 years later? And talk about those.
It is, and so we were talking about the early and late side effects from radiation, and the early ones typically are felt to be related to inflammation, and they usually resolve within a few weeks to months of radiation treatment. But once radiation's been completed, there can be some effect on scar tissue in the area of the prostate, as well as some weakening of the blood vessels. And so that's what leads to some of those late effects we talked about, with some rectal bleeding or some increased difficulty in urinating because of some scarring in the urethra. And those processes can evolve over the course of a year or more. So it's not necessarily something you'll see in 6 months. It can happen, 1 to 2 years down the road, even beyond that. And so that's part of the reason why, we like to follow people for years after their treatment, not just to monitor the PSA to make sure we've been effective, but also to monitor for any of those potential late side effects that may occur that may require treatment.
Excellent, thank you. That certainly answers the question. And so this is actually to you both, and because we've gotten quite a few questions across the board, that one of the things we didn't talk about, because we focused really on very early disease, is about salvage therapy, and what is, sort of one, if you could talk a little bit about what salvage therapy is, in what sequence different treatments are used for salvage, and then also what role hormonal therapy plays in the very early localized disease. So I can kind of punt that to you guys to kind of kick off. Maybe Kelvin, if you want to start.
Sure. Yeah, salvage treatment. So if you receive initial treatment for localized prostate cancer, we'll follow PSA, as Dr. Shinohara says. And if you get a rise in your PSA, that's called biochemical recurrence. And it depends on what you had done first, essentially. So if you had surgery first and you have biochemical recurrence, the first thing you do is staging to make sure that there's not metastatic disease. So most men will get a CT or MRI and a bone scan. And if that's negative, meaning no metastatic disease, then your treatment option for salvage would be salvage radiation, which Dr. Shinohara can talk about, or hormonal therapy, which essentially blocks the effect of testosterone. If you had radiation first and you have biochemical recurrence, you can have salvage prostatectomy, meaning removing the prostate after radiation. That is possible. It is more difficult. The tissue planes are not as great, and the rates of incontinence and erectile function are much higher. But that is a possibility. And then, as I discussed earlier in the seminar, cryotherapy is an option as well after radiation. And Dr. Shinohara can talk probably about both of those more. Yeah,
so specifically, after surgery, we are oftentimes asked either to give radiation in the event we see sort of more aggressive features. So if initially it was thought that there was a low-risk prostate cancer and it looked like it had gone beyond the confines of the prostate, or during the surgery there was concern that maybe a little bit was left behind, sometimes we see people to give radiation relatively soon after surgery, after continence and things have recovered. And that's commonly called adjuvant radiation. Salvage radiation is more when after the surgery has been completed, the PSA is undetectable, and say months to years down the road, the PSA becomes detectable again. In those cases, depending again on the age and the health of the gentleman when that occurs, you can consider adding some salvage radiation. There is some data that suggests perhaps adding hormones that may make it more effective. And the side effect profile is relatively similar to what we were talking about when we treat with early stage prostate cancer, although things like continence, because of having both the surgery and radiation, that may be a little worse, as well as decline in sexual function. The course is a little shorter. It's typically about 8 weeks. The things you saw about brachytherapy and things would not apply to salvage radiation. It's generally just external beam radiation as an option in those cases. And I echo Dr. Moses' treatment options for men who have started with radiation. You know, if we think there is a local recurrence because there's negative imaging for restaging, that typically we think of things like cryotherapy or hormone therapy. And again, as Dr. Moses had said, because of that scarring we talked about earlier that can lead to some of the late effects from radiation, we can make the what would be called a salvage prostatectomy a little more difficult because of that scarring.
Excellent. And if a man has had brachytherapy, would it be possible to do a prostatectomy afterwards? Would that ever be indicated?
It can be done. It's very difficult. I've done a few of those, and I'd prefer to never do that again. But it can be done, and there are surgeons who I don't know if they say specialize, but certainly have a higher volume of post-radiation or post-brachy prostatectomy, and some will even do those robotically. And but you have to do really, really good counseling with the patients, because the chances of erectile function or erectile dysfunction is almost guaranteed, and it's a little more difficult to get urinary control afterwards, so that most of those men are using, some pads on a daily basis, whereas with upfront surgery, especially in men younger than 70, you can get most of those men to either full continence or maybe one safety pad a day.
Occasionally we will do external beam after brachytherapy as well, but similar to surgery after brachytherapy, the side effects can be more significant. So it's usually a pretty in-depth discussion with the gentleman to make sure they're aware of the risks and whether they want to proceed or not with it, because it is a little more high-risk procedure the second time around.
Excellent, and that's great. That's great information for men to know if that should arise. I do want to revisit active surveillance just very quickly, because we did get another question. Just if you could tell us again, Dr. Moses, how frequently men generally have a repeat biopsy if they're have chosen active surveillance for disease management?
Sure. So the one center that's published the most on active surveillance is out of Toronto, and I follow their regimen relatively closely. So after the diagnosis, after I've done the biopsy, in some men I'll get MRI if possible, and at Vanderbilt they'll actually get a fusion biopsy, meaning they fuse MRI and ultrasound and get that repeat biopsy within 6 months or so. And that's basically the confirmatory biopsy. And once that's been done and you confirm that it's low-risk, low-volume disease, follow PSAs. Most people will follow every 6 months. and then we'll get another biopsy at about a year, and then if that one is the same, get another one at about a year, year and a half, and then another one at about 2 years, as long as the PSA is remaining very low and not increasing at a rapid rate. And, at that point, you can discuss with your physician just following the PSA, probably getting biopsies every 2 or 3 years afterwards, as long as the PSA kinetics or the speed at which the PSA is rising stays at a very low rate.
Excellent, thank you. I think that's important to know because that's it's sort of a new developing area that is being focused on. And I think this is going to be our last question, but I think it's a very important question, which somebody wants to know how do you know if your cancer has spread outside of the prostate?
So initially, for men who are diagnosed with low risk or intermediate risk cancer, the chance that it has spread to bones or lymph nodes is very, very low. So we actually do not get any other staging imaging in those men. With high-risk prostate cancer, meaning the PSA is over 20 or the Gleason number is 8, 9, or 10, or they have a grossly abnormal rectal exam, then we get a CAT scan, a CT or MRI, and a bone scan. And those are done to detect any metastatic disease. Now, for prostate cancer that has spread outside of the capsule of the prostate, meaning it's still localized but locally aggressive, a lot of times on your physical exam you can tell this, or on an MRI. MRI has very good anatomic detail. You can see cancer that has gone outside of the capsule, and that would change, at least from a surgical standpoint, my approach. I would not do nerve sparing on that side if it's on one side or the other. And I would take much wider margins in order to make sure that I've gotten all of the cancer. And so a lot of people will get MRI preoperatively just to determine any evidence of what's called extracapsular extension. I'm not sure if extracapsular extension changes the radiation plan, but certainly it does affect your surgical plan. And so that's one of the areas. CT is really not helpful as far as determining extracapsular extension, but certainly for metastatic disease.
And could you just explain very quickly what extracapsular means?
So that means, the prostate, if you think of the prostate like a small orange, and so then the capsule of the prostate would be the peel. And so any disease that has penetrated through the capsule of the prostate or through that orange peel, that's called extracapsular extension. So that means it's locally advanced, meaning it's gone outside of the prostate, but still within the tissues within the pelvis.
Just to sort of piggyback on that, with the extracapsular extension, from a radiation perspective, I think we're more inclined to recommend hormone therapy because, again, when the capsule has been broken, I think the thought is that that's actually a more aggressive cancer. Even if on biopsy it appears to be lower risk, we would be more inclined to recommend hormone therapy in addition to the radiation.
Excellent. Thank you so much. That's very informative, and I think most of our questions have been answered. I want to thank both of our experts and members of our medical advisory board. Thank you for your time and sharing your expertise. There were just a couple of questions that were about genetic testing, and I just wanted to say to the folks who had asked those questions, actually a few months ago, Dr. Moses did a program on genetic testing in prostate cancer, and so that is archived on our website and can be accessed and listened to. And on that note, I want to thank everybody for participating. Please take a few moments to complete the post-program survey so we can develop new programs around what your needs and wants are. And again, thank you very much, Drs. Moses and Shinohara. We certainly appreciate your time and all of your expertise in our program today.
Thank you.
Thank you. Bye-bye.